Surya, you've written, it's a right STN, which is pituitary CA-thyroid. Where are you? Sorry. It's not rose's position, it's rose. Huh? Rose is a flower. So it is not an individual. Okay? Rose position, caucus incision, you discussed it all. Also called as collar. And what are we planning? Total thyroidectomy with bilateral MRND type. The plan would be incision, and this should be extended to the mastoid process to become what is called a utility incision. Right. If you look at the patient's clinical profile, it may look like a lateral aberrant thyroid. So what is lateral aberrant?
It is metastatic node-pituitary thyroid cancer.
And there is a big node here. Gland is hardly palpable. So, this term which you were just saying, lateral aberrant, is no longer used. It used to be, but actually the lymph node has, the elements of papillary with thyroid. So they thought it's a lateral aberrant thyroid which has developed carcinoma. Yeah. What is a lateral aberrant thyroid?
So it's a metastatic lymph node when in a non-palpable thyroid gland.
Correct. So it's a clinically non-palpable thyroid gland, and there is a metastatic lymph node. Earlier it was taken as lateral aberrant gland only. Sabya, did you understand lateral aberrant thyroid?
Yes, sir. That's like glands are actually, so it's a metastatic lymph node in a non-palpable thyroid gland.
So the plan doesn't change. So we'll go through the same incision and we may extend it up. Okay. And what did the triple assessment show us?
Yes, sir. In the ultrasonography, there are wider than tall gland lymph nodules in the right gland with multiple collections, and in the
So it's a thorough history and clinical examination with high resolution ultrasound of neck followed by FNAC. And prior to FNAC, we get a thyroid profile done.
So we have done it. Now what did you find here?
So in the ultrasound neck, there is an enlarged right thyroid gland, and there's a solid cystic nodule which is wider than taller, and iso to hypoechoic. And also they have given two collections suggestive of cold abscess near the right thyroid gland. And in an FNAC, we have Bethesda 2 colloid goiter. Colloid goiter. So in clinically, we are palpating a right enlarged 4 into 5 centimeter firm to hard in consistency nodule, lump on the right side, which is moving with deglutition, appears to move with deglutition.
The CT has also been done, which shows element of papillary carcinoma thyroid with
How would
enlarged.
CT pick it up? What does the CT show?
So it shows a bulky thyroid with multiple enhancing mass lesions with calcification, suggesting carcinoma. And
So we are looking at microcalcification, taller than wide, rather than wider than tall.
on ultrasound, it was wider than taller only.
Yeah, that's what I'm saying. So this is not working out in ultrasound. So the benefit of doubt goes to the patient. We don't treat the CT, we treat the gland and the patient.
In CT also, so there are multiple necrotic lymph node in the bilateral level 2, 3, 4 and 5 lesions. So necrotic lymph nodes are mainly seen in papillary carcinoma of thyroid.
So indirect evidences of papillary carcinoma thyroid. So the plan would not be changing based on that. We are going for total thyroidectomy and bilateral neck dissection. Any questions? Now, patient has got lower TSH or higher TSH.
So said patient was euthyroid initially. Her initial reports were all within normal range. The latest report shows there is a high TSH with normal T3 and T4.
So high TSH goes in favor of malignancy or against malignancy?
So usually malignant nodes are
Answer the
non-functional.
question.
Malignancy, sir.
It goes in favor of malignancy.
Non-functioning
because
thyroid gland.
so not only is it non-functioning, it's also necrotic. So TSH also is an indicator, although it doesn't make any difference in our diagnosis. The minimum biopsy is hemithyroidectomy. FNAC has given you Bethesda 2. If we achieve on hemithyroidectomy, on frozen, if there's evidence of malignancy, you can proceed with it. That's the standard of care. The plan is total thyroidectomy, followed by
Bilateral.
bilateral neck dissection, especially right side being predominant, because left side are there level 2 nodes. Left side,
So right side there are enlarged lymph nodes which are necrotic.
left side,
Left side, sir, bilateral there is a 2, 3, 4, 5, sir. Left is smaller than right.
so that's the plan then. Now, what kind of a consent you have taken, Surya, for this patient?
Sir, we have taken consent for basically we are looking for recurrent laryngeal nerve injury. We have taken consent for that. We have taken consent for the tracheostomy in case patient would not be experiencing tracheomalacia. And then we have taken for consent for normal consent for surgery bleeding.
Sir, we have taken consent for voice
Hypocalcemia.
sir, as we are dealing with the recurrent laryngeal nerve.
Hypocalcemia.
She might need lifelong thyroid hormone replacement.
And hypocalcemia we have taken.
So, basically, for parathyroid and for recurrent laryngeal nerve, and also for external laryngeal nerve. We take it for external laryngeal nerve, we will be explaining to the patient that if she is a professional singer, she may have a problem. It may recover, it's apraxia usually. The timbre of the voice, the pitch of the voice may suffer. Positioning is reverse Trendelenburg. Neck is extended, head end is 15 degree up. We have discussed it because we will reduce the venous congestion but increase the chances of air embolism. So we should be careful, and to prevent it, we should ligate in continuity. And subplatysmal flaps are raised. The superior one goes up to the hyoid bone, not thyroid cartilage, which is what you traditionally read, because you have to also clear out the central compartment. Clear? Yes. So level 2, 3, 4, 5 and 6 to be cleared. Bilaterally, preserving all the other important structures, spinal accessory, internal jugular vein and sternometry. So lower flap goes down to the clavicle, which can be where the tendons of sternometry are visible. And like I said, the utility incision would be going to cover up. We can enter into level 5 here, and we can clear the level 6, 2, 3 and 4, 2, 3 and 4, 5. But level 1 is rarely removed, which is rarely involved. So we don't need to touch level 1. All right?
Yes, sir.
So that's, any question?
Bilaterally, we will be extending the incision, sir, in the neck.
Usually when you extend it on one side, it can suffice. If you need, you should extend it. So bilaterally we'll extend it. And this sometimes is also called as a visor incision. You can lift the whole flap up to the chin, but that is not required. We don't have to be aggressive extensively unnecessarily. The dissection of the lymph node involvement and its dissection doesn't change the overall survival, but it changes the recurrence rates. So recurrence, for every 4 recurrence, there is 1 mortality that you look at, something like that, some calculation. So not that recurrence is a great idea. If somebody is asking you a theoretical question, does it change survival to do a neck dissection? Your answer is no. But it changes the recurrence-free survival, which people feel is not a problem. It's a problem because the recurrence, whenever it happens, the cancer is of a lower grade, it's worse. So each time the recurrence would happen, it will not be the same cancer that you had initially. So from well differentiated, it may become worse. So therefore, recurrence is not a great idea. So we have to provide that complete clearance, certainly. Okay?
So in this case, the utility incision, this will directly be on that enlarged lymph node.
In this case, we may
Yes.
have to modify it a little, and the utility would help us. This is it.
Okay.
So we'll get enough space to,
Remove this.
when like we do it in any commando, that's not a problem.
Okay, sir.
Any other? No doubts? Let's go.
Thank you, sir.